I'd like to thank Alan and the organisers for the opportunity to speak here. The title that I've got fits beautifully with what Professor Nicol spoke about earlier, because I think we are at a very exciting time with opportunities now for pre-symptomatic treatments being suggested for Alzheimer's disease, but for other neurodegenerative diseases as well. And I think that's going to cause a real paradigm shift in how we think about these studies. And if they do prove to be successful, and there are huge challenges therein, I'll talk about some of those, it will change completely how we investigate cognitive problems. And so this is one of those moments in time, I think, when people may look back and think that was absolutely a false dawn and walk away from sort of disease modification at an early stage, when they may say that was the point at which we really changed how we thought about cognitive impairment, dementia, and interventions. So, with that, again, James very kindly went through some of this, so I won't dwell on it. I think you all know why dementia is absolutely the top of the research agenda, right at the top of government's anxiety, early morning awakening levels. It was the only area of medical research to have a G8 summit on it. So that tells you something. And this is what absolutely terrifies them. This is European numbers here, with the prevalence of dementia doubling with every 5 years over the age of 65. And as we grow older, as James was saying, those numbers are going to increase hugely. And the impact upon our health and social care systems are just devastating. 1/4 of hospital beds, 3/4 of those in residential care. Half of us here will care for a first-degree relative. And that really is because, as shown in this cartoon here, it's because of the change in demographics. I'm not projecting that out to the point where James had, where all of us would be living to 100. But if you look at the numbers of proportions of people who are living older, that has a huge impact upon the number of people with cognitive impairment. And the most common cause of which, because this is just projected numbers for Alzheimer's disease, is Alzheimer's disease, either in part or in whole. So what can we do about it? Well, unless we change the incidence, we will bankrupt our health and social services. But what's interesting is if we delay the onset of symptoms by 5 years, we halve prevalence within a few decades. And that's because this is a disease of late life and people die of something else. And so the ultimate aim is to compress more morbidity by people becoming symptomatic much later. So what are the proposed suggestions? Well, actually, some of the interventions we know would be a good idea. It's the problem there is not designing therapeutic trials, but it's about transferring what we know about risk factors into public health messages, be it stopping smoking, keeping active, reducing obesity, a healthy diet. But I'm going to talk more about the things down the bottom right here, about the sort of interventions that James was talking about earlier, and how can we do those sort of potentially dangerous, expensive, disease-modifying therapeutic trials. Is it really plausible? Is it possible? And what's the potential for them? So some basic requirements. So some of this may be completely obvious. Clearly, we need a scientific rationale for a therapy and for the stage at which to institute that therapy. So it's no good just looking at epidemiology and saying there is an association. And one of the issues may be that we don't really know some of the mechanistic roots from some of the associations down to causality and to therapies. But we clearly need to know something about what stage to intervene, and that's some of what I'm going to be talking about. If we are going to have a pre-symptomatic trial, we need to identify those subjects who are most appropriate, who will most likely benefit. We need to have a viable means for assessing the efficacy and the safety of those therapies. And if you just stop for a moment and imagine James at the end of his talk said that he'd be willing to have his therapy now, how are we going to monitor whether or not it's providing any benefit? I mean, we could ask him back to give another lecture at the BNPA in a year's time and see whether the talk is more stimulating, which is a high goal to do. But it's actually extremely difficult to track with clinical scales progression in people who are, by definition, pre-symptomatic. So that really puts a lot of emphasis on biomarkers or on very long or complicated studies. And that comes down to, is a feasible, plausible trial design possible in terms of participants, cost, potential, etc. So what's the rationale? Well, some of that was set out before beautifully. So it's when there's most to save, post-mitotic neurons with very little potential to regenerate are lost and they're not going to come back, and therefore we want to treat people when the minimum irreversible loss has occurred. And I think it's when we, either at an individual level or a governmental level, would want disease modification. I don't know how many people in the audience would want their disease slowed when they're bedbound and mute. Doesn't appeal to me. But I would like it at the point, even when I'm a bit symptomatic, because I seem to manage all right with a bit of memory problems already. But most people are kind and tolerate that, my not remembering their names. But a real driver has been the failure of phase 3 studies in Alzheimer's disease. And that was despite really good animal model mechanistic promise. And there may be some hints from recent studies. And so this really follows on from what James said. So one of the big studies that he mentioned that reported in the New England Journal of Medicine recently, they were back-to-back, the bapineuzumab study and the solanezumab. Solanezumab did not meet any of the primary endpoints in the overall study population, which was mild to moderate. So we're calling it mild to moderate. One of the things I want you to take away from this, and I will try and expand on during the course of this talk, is that what we have historically referred to as mild to moderate should not be thought of as that. We should be thinking of that as a long way down. That's a late stage of a disease mechanism and cascade that may begin 10, 15 or longer years before onset. So if we're looking at people with a mini-mental of 10 to 20, they aren't in the middle third of the disease, they're at the last sixth. Those are the, we've been thinking about these trials in mild to moderate or severe symptomatic subjects, much the same way as we might imagine chemotherapy being tried only on people who are in hospices. So, what did the solanezumab trial show? Well, in the mild subgroup, they showed that there was less decline, significantly, statistically significantly less. Wasn't a lot, 1 point less decline, but that's equivalent to what the donepezil studies and the other cholinesterase inhibitors showed. But what they also showed is they showed that the slowing was consistent over the 80 weeks, so suggesting that it was not a blip, a symptomatic benefit when you first start treatment, but it was consistent through. Now, there's a huge health warning that goes with any study which analyzes subgroups, because you can find just about every therapy works if you pick the right subgroup post hoc. But that's what has really stimulated this drive, which has transformed how therapeutic trials are being planned in the last 2 or 3 years. So what then are the benefits? Well, mentioned fewer neurons lost, more to save. So I wanted just to illustrate this. This is actually somebody who went into that immunotherapy trial that James mentioned, the phase 2 study. And so we were working at the other end from him, and he was looking at the pathology. We were analysing the worldwide phase 2 study. And we were seeing individuals coming into the study who looked like this, mild to moderate Alzheimer's disease. This hippocampus here has lost at least 40% of its volume already. This is not mild disease as far as the hippocampus is concerned. And just as a sort of slight diversion, it was a remarkable time. It still seems amazing to have been involved with it, seeing these scans come in with all this promise from the mice work, and then seeing some really unusual changes. We were analysing the serial changes to look for brain shrinkage, and then we saw scans appear where it looked like there were focal areas of inflammation, brain swelling, and we were registering the scans, matching the second scan to the first, so we knew that was a novel and treatment-related change. So, and that has actually made a huge change to the whole way the field thought about immunotherapies and treatments for Alzheimer's disease. So then, it may be that it's all just, if you intervene late, it's just too late. But I think there may be more to that than that. There are some features about neurodegenerative diseases which are worth noting. First of all, they involve spread. Whether you believe that in terms of a mechanistic prion-type mechanism, or whether you actually just take observations of what happens within the brain, they do involve a spreading process. They clearly accelerate, and they involve a cascade of different processes. It is not like a single insult, and then you get the downstream consequences. A whole series of other players come into play. So what's the evidence that if you intervened in a mechanistic way early enough, you might change disease? Well, there's an interesting biological experiment that's done that was reported from the Icelandic study, the DECODE study, where the whole of Iceland gave DNA and were followed, a very homogeneous population, largely Vikings. And this mutation in the APP gene was shown to be 5 times more common in people who were healthy, elderly, without cognitive impairment than in people with Alzheimer's disease. And when one looked at what that did, the A673 mutation is 2 amino acids along from where beta secretase cleaves out A beta out of APP. And what you've got is, if you carry this mutation, which I'm afraid only a very small proportion of Viking descendants do, then you are changing your beta secretase function in a way that reduces the amount of A beta that you produce, but it does it over a lifelong effect. So if you intervene early enough, at birth, genetically, you can reduce symptoms. Now that's quite tricky, but what can we do perhaps a little bit later? Well, I think there are some interesting lessons from other diseases. I went to a fantastic talk about the history of therapies for MS. And many of this is what we aspire to in some ways. Disease modification has been changed. A disease that when I was a medical student we had nothing. Now have several therapies that slow disease progression, really slow it. Those therapies that have been shown to be successful all have failed and continue to fail at the secondary progressive stage of MS. As though there is a second process that gets initiated where you're intervening in the upstream is now too late. And the analogy that I've heard drawn here is, imagine a house is set on fire by an electrical fault. If you turn the electricity off, it's not a good way to put the fire out. It's too late. So let's think about some of these this idea of spread. Work from Brack and Brack shows that we do have, at least in terms of the tau pathology that James talked about, a relatively focal, in many cases, start in the entorhinal cortex, hippocampus, and then spread to the time when we're symptomatic. We're well beyond this stage. We've got tang throughout our neocortex. And it's not just at the histopathological level we can see this spread. This is a series of scans that involve what I will talk about a few times in this talk, something called registration. So I'll just stop for a moment to talk about that. So this is a technique that we developed to try and look at the earliest changes when I was doing research on familial Alzheimer's disease. And what it essentially consists of doing is taking a series of scans, and then you take the second scan and you match it to the first, and then you subtract the two to see the change. Essentially, it's very simple. It's the same principle that 7-year-olds use to decide who's taller in the playground. You match back to back and you see the change. So that's the idea. So what you see here, this is an individual who enrolled in one of our longitudinal studies as a control. That's his first scan, and there's just a copy of it there. So they're the same. You'll see a series of scans that occur a year after each, as he went into this study, which was meant to be several years, looking at people who had subjective memory complaints, which he did not. He was a control. So that's a scan a year later. Just concentrate on the top row first. I'll talk about this in a second. And that's a year later. What I'd like you to see is how, I'm biased here, how beautiful this is. Isn't it wonderful how perfectly matched they are? Yes, it's fantastic, isn't it? Okay, so remarkable registration. These scans have been registered. These are acquired with a resolution of about a millimetre and a half. They are registered to 0.2 of a millimetre, 5 times more precisely than the scan itself. That's because the brain, this is something that's not well known, was designed for registration. Little known fact. Because of the complexity that it's got, the shape is such that there's only one unique match. And you've got volume change internally, the ventricles, and externally. So it's perfect for matching. It's much a better single unique solution than just putting a square peg in a square hole where there are several options. There's only one match. Okay, so if we carry on another year. Now around about here he complained about some cognitive problems. And he said it was his memory, but actually when his memory was tested it was fine. But he was starting to have some visual processing problems. And what you see along the bottom row, in green, I don't know whether you can see it at the back here, there's just a tinge of green at the back of the brain here. And that is quantifying on a voxel by voxel basis what has changed relative to the first scan. And so these changes, which predated his symptoms, suggest that he's losing more brain than he should be at the back of the brain, parieto-occipitally. And as you can see, that spreads and becomes more. And if you look from across the whole 4 years, or 5 years, you can see the ventricles have got larger, but it's actually very difficult to discern the difference on scan by scan. But what this shows is that we have an initial focus of loss, which spreads, and the spread is not simple contiguity. So it's something to do with how the disease process may start quite focally, and then it will progress along cortical spread, networks, I don't know. Those are questions we need to answer. So then I've mentioned, is there a conversion in the nature? Is it just that it spreads? So more damage, it's harder to stop? Or maybe it might be something more. And we heard from James again about the microglial response, and there's some evidence that it may switch from being possibly beneficial to damaging. And we need to know what happens to this early amyloid deposition that leads to tangle formation and neuronal destruction. It may not be that that's an inevitable consequence, that we need to bring in other players to get the next step in the cascade. And genetics seems to be telling us that there are multiple different contributory pathways, which have been interpreted as there are alternative routes, or these things need to act in concert. But an alternative, but not exclusionary, explanation is that these genetic influences are key to the next stage in each of the cascade. So you've got something that leads to amyloid aggregation, you've got another step which may be genetically influenced about what that amyloid does to you in terms of tau formation, and then later steps about how that leads to inflammation and to neuronal destruction. Sequential pathways. And now we're starting to be able to see those effects. And what the imaging and the CSF studies have been showing is what pathology has been telling us for a while, that there is this long prodromal presymptomatic period, and clinically normal individuals who have got evidence of amyloid pathology, either from CSF examination or these amyloid PET scans, have progressive structural functional abnormalities, they have subtle cognitive deficits, all of which cumulatively, additively lead to the chance of you getting cognitive decline. And we know that there's increased atrophy rates, and I'll talk a bit more about that, not just in Alzheimer's disease, but in other neurodegenerative diseases, and that these become pathological prior to symptoms. But what we don't know is the sequential changes, the time course, and the influences, and that's a major challenge at the moment, and that's where the field is moving. So just to illustrate that, this is the prevalence of Alzheimer's disease, because there are some hints from cross-sectional studies as to what that gap may be. How long do you live with amyloid in your brain before you become symptomatic? So that's the prevalence of Alzheimer's disease. That's the prevalence of plaques at post-mortem in healthy controls. So both show this exponential rise, but it looks like an offset of 10 to 15 years. And amyloid imaging, we could add more dots now because there's more studies, seem to track the plaques. So what we've got is that the amyloid imaging is showing that indeed it's picking up things at about the stage we would imagine with pathology, and that's 10 or 15 years before symptomatic Alzheimer's disease. These are two individuals, patients of mine, both with mild cognitive impairment. This individual has this red, yellow, high amyloid deposition throughout the brain. This individual just has the background white matter binding. This individual went on within 2 or 3 years to Alzheimer's disease. This person remains well. And that's just an anecdotal single case, but it's been borne out by the long studies. Amyloid imaging is also bringing up some really surprising results as well. This is in familial Alzheimer's disease. Who would have thought that the earliest changes pre-symptomatically would be in thalamus and basal ganglia? And looking at from a big Colombian kindred, this is probably the Colombia owes this to the conquistadors, not a great donation to Colombia, but there are 5,000 individuals thought to be descended from somebody who carried a point mutation in presymptomatic 1, which causes early onset Alzheimer's disease. And there's a whole region where this is recognized to run in many, many families. And a study looking at these individuals, this is just cross-sectional. If I can take you through this first, this is the age of the individuals. Green are the people who are non-carriers, don't carry the gene, other members of the family. Blue are the people who are asymptomatic, the light blue. And red are the people who are symptomatic. And up on the y-axis is how much amyloid on imaging they have. So we seem to have people who are very young, maybe 15, 20 years before becoming symptomatic, are like the controls, but several years before, they're becoming high levels of amyloid in their brain. What's that gap? 10 to 15 years. What are the processes that get a part of that 10 to 15 years of progression? Again, these are two of our subjects. These are symptomatic individuals with Alzheimer's disease, similar level of severity. Amyloid scans which look very similar. But if we look at the level of inflammation with a PET tracer that is thought to bind activated microglia, we see this individual with almost no binding and this individual with a lot. Now that may just be the noise in the tracer, these are noisy tracers, but it may be saying that two individuals with the same level of amyloid may be dealing with their amyloid in different ways, which may give us clues. And this is an alternative version, actually I think James's cartoon was much nicer, suggesting that we have these genetic influences, and in sporadic cases, influences we don't understand, leading to amyloid aggregation, causing these plaques to be deposited. We get paired helical filament, tangle formation, and neuron dysfunction and death, and then dementia. And something is linking these different steps, and we don't fully understand what does it. We do have an idea from biomarker studies of some idea of the temporal ordering. And we think, and these are just largely conjecture, that amyloid is first, and then we get synaptic dysfunction, followed at least by CSF tau, and much later brain structural changes, and far, far to the right are these functional changes that mean that we no longer manage in our daily life. And a real change that we're going to see will be, I predict, you'll be seeing a lot more of, is tau imaging. Amyloid imaging has spawned whole new meetings and huge numbers of publications, and tau imaging is the sort of new kid on the block. And this is just from really the last year or two. These are two individuals. First, the top level scan here is somebody with Alzheimer's disease. Note the small hippocampi, large ventricles, lots of space around the brain. This is a normal control. This is taken from this publication from last year and presented in Boston at the Alzheimer International Conference. So just keep an eye on the hippocampal changes there. We look at amyloid imaging now in that individual. There's very little amyloid tracer picked up in the hippocampi. There's very little in the normal control apart from that non-specific white matter binding. But the Alzheimer subject has it all around the cortex. But this new, and there are at least 3 different tracers which bind tau, seems to be picking up areas where we might expect tangles to be. And autoradiography studies seem to suggest that's what it is indeed binding. So we now are able to see the downstream atrophy, we're able to see amyloid appearing in the brain, and now we'll be able to pick up tau. So what does this tell us about the timing? Well, I mentioned that severely affected individuals may have a hippocampus down by 40%. when people present to clinic, they are already 15-20% down in terms of their hippocampus. So long before we had any of these clever PET tracers, there's a message there. If I give you one other bit of information, you can tell me how long people on average have had this excess destruction. And this is the bit of information you need. So they are atrophying hippocampi at 3% per annum more than normal controls, but they present with the hippocampus 15 or 20% down. So that tells you, without any longitudinal or clever studies, that there's been excess atrophy in that hippocampus probably for 5 years. And that seems to chime with the much more recent studies that were done with amyloid imaging and PET. But we don't quite know how to put on the timeline those different aspects of that cascade. And one of the ways that we were interested in, this goes back now 20 years, was whether we could look at people who carried a mutation in these genes that cause early onset Alzheimer's disease. It's autosomal dominant, 100% penetrance. There's one case in literature where apparent non-penetrance, maybe a bit more. But to all intents and purposes, within these families, people get disease age 40 or 50 in a fairly family-specific way. So if you've got other members in your family getting it at 50, you're likely to get it at 50, plus or minus maybe 5 years. And so almost 20 years ago, for my thesis, I was tracking individuals who were at risk. We didn't know whether they carried a mutation or not, but we knew that there was a family history of Alzheimer's disease and that they were approaching 10, 15 years from the age in their family. So we followed them sequentially. And here's a video from one of those individuals. So I think she's describing a very difficult cognitive task, one which I struggle with. If you try and take 2 kids across London on the public transport, it's tough. Everybody in her family thinks there's something wrong with their memory. She's several years from predicted age at onset, but she's worried about her memory. She's doing quite a high-level job. She's doing all right. She had recently felt a bit more stress, had a minor prang in the car, but cognitively she scores 29 out of 30. Is she okay? Is she gene negative or gene positive? I'll just show you her serial imaging and then ask you that question again. This is a time lapse of annual imagings from her. The first few scans, you don't see that much change. Change? So when was that video in that series? So this is the first few in that time lapse. It went on for a few more years. 93, 4, 5, 6, 2 in 97. And if we color code that with the changes relative to baseline, we can see that there are extensive changes, even this early here, but very widespread, noticeably ventricular enlargement, widespread cortical changes. That video was taken in November 97, which scored 29 out of 30. We sadly have both genetic and post-mortem confirmation of familial Alzheimer's in her. And there is a little bit of change, but you're absolutely right. Some of these PSM1 cases have relatively little hippocampal change early on. They get more of a posterior cortical change early on. And that's why that is we don't fully understand. It may be something to do with the vulnerability of the hippocampus as you go older. But this just looks at a really gross measure, whole brain volume. And this is her scans. These boxes here are the timing of each scan. And you can see, even really early on, she's coming out of the normal range. All that would be regarded as normal. In fact, all cross-sectionally, all of these scans, all the way here, were cross-sectionally regarded as normal and were reported independently as normal. And the video is about here. And if we take individuals like this and we combine other individuals who've been scanned serially, we need to try and put different individuals on the same time course. And we just happen to find that we happen to have a mini-mental of 23 out of 30 to have been done at the time of a scan for each of these individuals. So we put them onto, this is sort of a fairly crude way of trying to align people in timing. You can see that there is some subtle but clear and statistically significant acceleration. So this disease starts focally, it spreads, and it accelerates. And it accelerates in terms of downstream structural losses over at least 5 years, gradually going from a rate of brain atrophy of 0.2% per year up to 1.5% over that 5 to 6 years. And if we try and combine those, what we see is that this is the gross brain volume as a single number, and these are the changes that occur, trying to localize where they are occurring. We can take several individuals, a bit noisy data, we model it, we can show that for hippocampus, people are coming off, these familial Alzheimer's cases are coming off the normal control 5 to 7 years before diagnosis of Alzheimer's disease. So not the 15 years we were seeing with amyloid, but definitely not at the time you get symptoms. So is this just Alzheimer's disease? Well, turning to some non-AD dementias, this is a study, Sarah Tabrizi at Queen Square leads. This is caudate volume, again using a registration-based technique to measure caudate changes. The green is the normal controls, age-matched. The red and orange are the people who are already symptomatic of Huntington's. And these individuals here, who are showing over this 3-year study, increased rates of caudate loss, are within 10 years of expected symptom onset and more than 10 years. So there are structural changes in these other neurodegenerative diseases that predate. Here's a tau mutation family, which causes frontotemporal dementia, in actually a rather less predictable age at onset. So we followed this individual, and you again will see a time lapse. She's working in education, doing quite a responsible job. She's in her 50s. Pathological changes, asymmetrical hippocampal atrophy, real loss of the temporal lobe, and remarkably, this is the point at which symptoms were first suggested. So all those scans, I just go back in reverse, run time in reverse. Those changes, this person was working in quite a demanding job, and family just sort of said towards this sort of stage that there were behavioral changes, seemed less concerned, but still seemed to be doing. And neuropsychometry at this stage was normal. And this just shows that 16-year spread, showing that these changes can occur early. But these time lapse of studying people who are presymptomatic raise actually quite a few other questions. What I'd like to say, this is somebody who carries a progranulin mutation, so another cause of frontotemporal dementia, typical onset 50s or 60s. And if I just show you, this is just a time lapse over just over 2-year period, and it will circle back. So look at this left temporal lobe just as being dissolved away over this couple of years. That's remarkable. But what's even more remarkable, what do you see? This right temporal lobe isn't changing. You have a genetic mutation that produces protein changes throughout the brain, and only half of the brain seems to be getting the downstream loss. There must be another cascade coming in here. Just remarkable message from this hemisphere being devastated while this looking normal. So, I hope I've convinced you that we can detect changes presymptomatically in a number of diseases, and that it's not a falling off a cliff, flicking of a light switch. This is a gradual process of spreading, accelerating change, which can be tracked. And it can be tracked by a number of biomarkers, imaging just being one of them. Very sensitive cognitive changes probably have more potential than we have recognized as well. But now, that's the plausibility. What about the perils? So, on the one hand, actually I'm going to stop. Just because it's after lunch and you've got that sort of sleepy feeling. If I said, I've shown now that there is the treatment that's going to slow your chance of getting Alzheimer's disease. Who, without revealing any of your past medical or family history, who here would want it now? Okay. Who would want it only when they became symptomatic? Who would want it end stage? Nobody would. Who would want it 2 or 3 years before they became symptomatic? Okay, so a few people. Who wants it 20 years before? No, James does. Okay, now let me tell you that this is an extremely dangerous therapy. It has major side effects and a high mortality. And there are a number of other treatments in the pipeline which look being a lot better. Who wants it 20 years before now? Not so many people. So that's the balance. Is it earlier the better? And lots of people do believe that if we are trying to intervene, certainly with a therapy against amyloid, there are people who firmly believe that even 20 years before will be too late. And are suggesting that in familial Alzheimer's disease, people should be given immunotherapies aged 18, the moment that they can legally consent. But there are a number of dangers there. First, the reason in favour clearly is there's greater chance of success, particularly if these secondary mechanisms I'm talking about are critical. You may be able to get away with a much lower dose, like the genetic mutation that just changes beta secretase activity by a little bit. So, but you have it over a long period, you have very little side effects, it all works very well. Now, I think if we really knew, I'm going to say this, I'm not really sure about this. I was going to say that if we all knew that we had an aspirin and that would stop our Alzheimer's disease, we'd be happy taking that from age 18. Though, of course, public health is littered with the fact that we know that things like losing weight is good for you and stopping smoking is good for you, but the population doesn't really change that. But that's a separate talk. So here's the twist. If you want to recruit people many years before onset, there's much less certainty that that individual ever will have symptoms. It's easier in the familial cases, but think about sporadic disease. We see large numbers of people who die with lots of amyloid in their brain completely symptom-free. 25% of normal 75-year-olds recruited into the Alzheimer's disease neuroimaging initiative had evidence of amyloid in their brain. They were in the control arm. They weren't the MCI arm or the AD arm. And some of those individuals will die perfectly happily. Well, I don't know how happy they are, but they will die without being worried by their amyloid. So you need to think about that. And it depends upon the risk-benefit. Clearly, we're all happy to take, well, most of us have fluoride toothpaste because we don't think there's much in the side effects, and it seems a good idea. But we might be better to wait for the next trial to come along. That's at a personal level. But at a trial design level, I'd like to suggest to you there's something even more dangerous, which is heterogeneity, the dreadful H word. Because if you're trying to track change in a trial where you have some people who are 10 years or 20 years before symptoms in the same arm as somebody who's got 1 year till symptoms, you have huge heterogeneity. And you may just have more failed trials, and then pharma will give up on Alzheimer's disease as a therapeutic target. So just to say that again, it's variance or heterogeneity that drives sample size. Why were those immunotherapy studies with 2,000 subjects in them? Because people were at different stages and had different rates of progression on the outcome measure. You might have even more of a trouble if you just took people at risk of Alzheimer's disease or took all 45-year-olds. Because some of those people will get Alzheimer's disease at 70 and some will never. That's dreadful heterogeneity in terms of anything you want to measure. So outcomes are all about signal to noise. Heterogeneity gives you noise. Between subject variance is a killer in terms of trials. And that varies with where you are on that pathological pathway. So you would need very large numbers of subjects or novel designs. And I just throw this out here because one way we may see trials changing is instead of the typical parallel group design, we may end up with tracking people for a year and using their within-subject change, be it cognition, MRI, CSF, amyloid, to then use as a change from your rate of change. So within subject change being the thing that could get you around some of that between subject heterogeneity. And I think these other imaging agents will be adding more fine-grain assessment to where you are on that stage. I think we will be seeing more studies requiring amyloid or tau imaging, more studies requiring CSF. And I think our clinical practice and our research practices will require us to be happy with invasive therapies and invasive investigations, including CSF. So where are we now? Well, the trials in familial Alzheimer's disease launched in 2012, and these are the ones. I think there are others in the pipeline, but these are the ones that I'm aware of. So secondary prevention or pre-symptomatic trials are underway. So it's not that they're fanciful, they're happening. Whether they will work is not the $64,000 question, but the $64 billion question. So the dominantly inherited Alzheimer network is a group of centres in the US, Australia and the UK. We're the UK centre here at Queen Square. If you've got any familial Alzheimer's disease individuals or families, we'd be very keen to see them, because we're recruiting people who are at risk of, they don't need to know their genetic status. That was deemed just ethically too difficult. So we will be exposing people to therapies rather than exposing them to genetic knowledge. PS1, PS2, APP, they're going to get an anti-amyloid immunotherapy. It's going to be a 2-year biomarker-driven study of over 200 individuals. And look at this heterogeneity. They can be within 15 years before or 10 years after expected parental age. Then there's the Alzheimer Prevention Initiative, which is based upon that Colombian kindred, aiming to recruit 300 members with a 5-year study. And there's a very large study that was just funded November last year of people who are ApoE4 carriers, homozygotes. So they have 2 E4 alleles. They are roughly 8 to 9 times risk, and they get the disease about 10 years earlier than on average other people with Alzheimer's disease. We're going to recruit 650 cognitively healthy ApoE4 individuals aged 60 to 75. And there may be a UK arm recruiting out of biobank is one suggestion at the moment. Getting even bigger on using both, this is the Tomorrow trial, which is looking at almost 6,000 subjects at risk because of a combination of E4 and the TOM40 minor allele. So those are all based upon genetic risk. And then there's another trial which is really quite interesting because it takes a different approach. It takes screen many thousand individuals with amyloid imaging to get 1,000 positive normal 65 to 85-year-olds, and they'll get 3 years of treatment with that solanezumab, that study which I mentioned, reported in the New England Journal, and then 2 years further clinical follow-up with clinical outcomes as the primary outcome. So I think they're plausible, they're happening, but they are full of challenges and dangers, and we clearly need effective treatments. The tragedy would be if we have effective treatments and we miss the signal. And this is what happens when somebody has familial Alzheimer's disease and are already got a mini-mental of 20. That's what happens over 1 year, 18 months, and then a further 18 months. These are devastating diseases. This is the switching off the electricity after the house is burning. We've got to go earlier, and there is a lot to save. So those 3% per year losses have got to be stopped. So they're starting. There are also trials starting in Huntington's and in pre-symptomatic FTD being planned. They're plausible, but they're with perils. We mustn't neglect modifiable risk factors now. Spending millions of dollars on trials when we could be trying to improve the cognitive health of the population at the same time. And clearly, these studies are going to take years. We need other effective symptomatic treatments, and we need care at all stages to be a lot better than it currently is. Thank you very much indeed for your attention. Thank you.